Okay, part 2. So we're going to start with glomerular filtration. What is it that's going to help the fluid move out of our glomerulus? And again, if you guessed pressure differences, you are correct. So what pressures are we working with here? We're working with Starling's forces, hydrostatic pressure, and oncotic pressure. So in your outline, we have some pressures that are going to favor filtration or moving out of the bloodstream, which is the glomerular capillary hydrostatic pressure. So that is PGC. So the hydrostatic pressure, which is blood pressure, right? The force of the blood in the capillary is going to push the fluid out. You can see we have a really big arrow here, 60 millimeters of mercury. And this is going to be high because of the resistance of the efferent arteriole. So this efferent arteriole has high resistance. So you can think of this as being a little bit narrower than the afferent arteriole. So blood has a nice time coming in. A lot of blood comes in, and then it's kind of backed up a little bit. So it's not going to leave as fast as it came in. So that means that the pressure can build up in the glomerulus and push it out. The Bowman's capsule has oncotic pressure, but it's not anything. So it's very low due to the lack of protein in the filtrates. Because, again, right, should we have protein here? No. No protein should be here. So there's not a lot of oncotic pressure of the Bowman's capsule. So where is I? Oh, this pi. Oh, yeah, here's Bowman's capsule oncotic pressure. Then what's going to promote filtration in is the hydrostatic pressure of Bowman's capsule. So the Bowman's capsule has pressure because a lot of fluid is coming out. It's going to want to push back, but not as much as the hydrostatic pressure. And the oncotic pressure is higher than in systemic capillaries because there's plasma proteins in the glomerulus, and you have a very small volume of plasma. So it just tends to be a little bit high, 29 millimeters of mercury. So there is pressure coming back in. However, when you do the math and you look at all the pressures at once, you do find that there is a net 16 millimeters of mercury pushing the fluid out, so it favors filtration. Okay, so this is our filtration pressure. Filtration fraction just means how much of that blood is getting filtered, right? So it is the glomerular filtration rate over the blood flow. So it's around, so if you do the math, the plasma flow rate is 625 mils per minute. The glomerular filtration rate is about 100, it can only filter about 125 mils per minute. So if you have 625 mils coming in, you can only filter about 125 of that, then you have a 20% filtration rate. So not 100%, right? Pretty low, 20%, but it gets the job done. So the kidneys have to monitor the filtration rate because the blood pressure, this should make sense to you. If you have really high blood pressure, coming back to the picture, right? If your afferent arteriole coming in is super high, you're increasing your blood pressure. That's going to really change how much is being filtered out, right, by your kidneys. And so you're going to want to monitor very closely the filtration rate within the glomerulus. And so when you look at this graph, we can see that here's our glomerular filtration rate, right, at 125 per minute, and that's normal. And we can see that this graph shows you that between 80 and about 180, mean arterial pressure, this is your systolic pressure, right? Systolic blood pressure. So it's pretty constant in this sort of normal blood pressure range. You would argue that 180 is pretty high. However, look at pathologically high blood pressure. So if you go above 180, remember that this is an exponential curve. And so it's not a linear relationship where you have an incremental increase in blood pressure and you have that same intermittent increase in filtration rate. It's actually doubled. So you have a small increase in blood pressure and you can really have a really big jump in filtration rate. So that's not healthy. And then the opposite is true too. So you can see how we have another very slippery curve here, a steep curve. And so a change, once you go beyond 80, when your blood pressure gets lower, the filtration rate drops drastically. So you have to tightly regulate the filtration rate so that you can get an optimum 125 mils per minute. So there's two ways that that your kidneys can do this, and this is intrinsically and then extrinsically. So intrinsically, there's two ways. So here we're feeling an increase in blood pressure in both of these scenarios. Let's just follow one. So let's just look at our increase in blood pressure. So we have our afferent arteriole here, feeling that increase in blood pressure. Let's follow this line. That's going to lead to an increase of glomerular capillary pressure, of course. That's going to then increase your glomerular filtration rate, right? Down the road, it's going to increase that filtration rate. It's too fast. We're not filtering efficiently. And so, we're going to be losing a lot of fluids. And so we're going to look at what's happening here. So this is called the myogenic regulation because remember, this is the same thing that arterioles had when we talked about the systemic blood supply, that the stretch on the arterial smooth muscle wall can actually cause that constriction because there's stretch gated channels that can respond and then contract those smooth muscles when that stretch gated channels are stretched. So it's going to have constriction, that's going to produce resistance, that's going to reduce our glomerular capillary pressure, right? And that's in response to that increase in glomerular capillary pressure. Another way to do it is with this called tubuloglomerular feedback, and that is with the macula densa, okay? So we, again, have an increase of blood pressure. We are feeling that in the glomerular capillary. We're getting a higher filtration rate. What the macula densa does is it feels what's happening in the afferent arteriole, right? Because it's part of the afferent arteriole. It can increase, you feel that increase of flow. Then it's going to secrete these paracrine secretions. So it's not known what it is, but there's a substance, and paracrine just means that it's going to local tissues around it. So it's not going to diffuse into the blood and have action elsewhere. It's just locally active. So these are going to cause vasoconstriction, increase resistance, decrease the capillary pressure, and that's going to ultimately negatively feedback on this high pressure, which would then lead to minimizing your glomerular filtration rate. Extrinsic control, okay, so this is outside the kidney itself. We're going to look at the example of low blood pressure. So low blood pressure, or low volume, I should say, is going to be coming from if you're losing a lot of fluids. So the examples here is hemorrhage or sweating, but it could also be you have diarrhea, you're vomiting, something where the blood volume goes down. And then we can see that it's going to create a lower venous pressure. The baroreceptors, remember these are your low pressure baroreceptors, are going to get feel this low pressure. Your sympathetic nervous system responds. In the kidney, what does the sympathetic nervous system do? The same thing as it does systemically, it vasoconstricts. So it's going to constrict the afferent and efferent arterioles, and it's going to increase the resistance. Okay, so it's going to increase total peripheral resistance. And when you have an increase in resistance, it's going to make that blood move slower through the glomerulus, so you can have a decreased glomerular filtration rate. When you do that, you're just not going to filter as much. You're not going to produce as much filtrate. And then down the road, you're not going to produce enough urine or minimize the urine. And that's great because you're losing fluids, right? Imagine having diarrhea and you have to retain all your fluids. So you're going to make very, very little urine. So that's going to reduce your fluid loss. Okay, so that's going to help feedback on your blood volume. You're going to retain that fluid. Okay, so, and then we have a smaller feedback, negative feedback, where we look at the total, the peripheral resistance will help increase your blood pressure. And that's going to help to mediate that drop in blood pressure. Okay, let's move on to look at the next topic, which is going to be reabsorption. So you can take a look at this table and look at what is being lost or filtered at the glomerulus, and then how much is reabsorbed, and how much is the percentage of what is being reabsorbed. So look, water, we are reabsorbing 99% of our water in the kidney. So we lose 99% of the water. We lose 100% of the water, or 180 liters. We reabsorb 99.2% of that. So we lose very little water. If our kidneys did not reabsorb water, we would dehydrate very, very quickly, okay, within hours. Glucose is 100% reabsorbed. So you lose 800 millimoles per day, you reabsorb that, and so you don't lose any glucose. This is why glucose is a great tool to look for in urine if there's a disease state, right? So because under normal circumstances, under normal glucose concentrations in the blood, your kidneys should be able to reabsorb all of it. But if you have an excess amount of glucose in the blood, your kidneys are not going to be able to reabsorb all of it, and you'll lose it in the urine. Urea is 50% reabsorbed. So you do reabsorb some of urea, but you lose it because it is a waste product from protein metabolism. Salt, we don't lose a lot of salt. We reabsorb that. Unless you have a very, very salty meal, then you can lose more of that. Potassium, calcium, chloride, and bicarbonate. So you can see bicarbonate too. This is our buffer, right, in the bloodstream. And we don't want to just waste it, pee it out. So we're going to reabsorb that as well. So your kidneys do a lot because what's filtered is actually quite a bit of material. So all of these substances are filtered. But because of this powerful reabsorption step, we can get it all back. So what are the barriers to reabsorption? So if you're a molecule in the lumen here, we're going to move across the epithelial cells of the tubule itself. Then we have to consider the basement membrane. And then we're going to enter into the capillary endothelium. So the capillary endothelium is not as big of a barrier as the tubules are, because the capillaries are supposed to be leaky and they are supposed to allow filtration to happen or diffusion across the membrane. But the tubules are more of a formidable barrier. So they have special little anatomical features, pumps, transporters, active secondary primary pumps, channel proteins. So they're going to be littered with items to help molecules pass. So here's our picture, right? So the way that things are reabsorbed is all the tricks of the trade. So active transport, where we have, sorry about that. So we have on the apical membrane, right, on the membrane that faces the filtrate, X and Y here, you'll have a transporter actively pumping it in. And since a lot of times this works for glucose, since we're kind of pumping it in, we're making a higher concentration gradient inside the peritubular cells. And that way the exit can just be diffusion. So this can be passive. So if you have active pumping in, a lot of times there's passive diffusion moving out. So that's active solute reabsorption. We can have water reabsorption is passive. Water moves through channels. It moves through aquaporins, and then on the capillary end, it can actually just move through the loosey-goosey cells of the capillary. They're not tightly joined. And then lastly, passive solute reabsorption, which is just diffusion. So if there's a high concentration of one solute and it's lipid permeable, it can move into the plasma the plasma of the bloodstream. All right, so let's talk about, so this is just an example of glucose, right? So glucose, we have a active transport. This is a secondary active transport mechanism. But since we have glucose coming into a higher concentration, right, because we're actively pumping it in, then that means we can just diffuse the glucose out and glucose travels into the blood plasma, okay? So secondary active transport, it's moving with sodium, right, and the sodium is getting pumped out with primary active transport. Okay, let's take a look at, so I do have secretion on my outline. And secretion is just moving from the peritubular capillaries into the tubules. I don't have a picture of that, but a lot of substances that the ones I listed are going to be secreted. And I am now on transport maximum. So let's talk about transport maximum. So what happens is, because glucose, we have a transporter. There's a specific molecule that's going to move glucose from that tubular fluid into the cell. So you have a limited amount of these transporters, and those transporters can get saturated. Okay, so the carriers I have in the notes, the rate of transport maximum is basically when the rate of transport is, I hate to say it, but maxed out, meaning that all the carrier molecules are saturated and they're moving as much glucose as possible from the filtrate into the cells. So there is a maximum. So here is the graph of the maximum, right? So this is looking at glucose. So we have the glucose transport maximum is about 375 milligrams per minute. Okay, so every minute, the PCT can only transport 375 milligrams of glucose, because above that, there are just not enough glucose transporters. If you have more than that in your bloodstream, you're not going to be able to move the glucose from the filtrate into those peritubular cells, okay? Or into the capillaries, or into, just away out of that filtrate. So it turns out that your normal blood glucose levels in the blood is anywhere between 80 and 100 milligrams per deciliter. So here we have 100, but normal is below that. So it's kind of here to here, right? This is the normal range. So the purple line, or the magenta line, is reabsorption. So we can see that at normal levels of blood glucose in our bloodstream, in our plasma, we can no problem, right? We are way below transport maximum here. So we can clear that glucose, we can move all the glucose from the filtrate back into our bloodstream. No problem. So, however, when your blood plasma concentration of glucose comes up, so if you have diabetes and you have lots and lots of glucose in your bloodstream because your cells can't take up glucose, right? Then you're going to have an elevated, let's go here, right? You have an elevated glucose level. Actually, let's go here, 300. If you look at 300, something around there, we have maxed out, right? You can still filter it, but we are not going to be able to reabsorb it because we've surpassed our transport maximum of glucose. So what's going to happen to it? It's going to get excreted in urine. Okay, so this graph just shows, the green line just shows you that as you increase the concentration of glucose, you're going to then also increase in a linear way how much is found in your urine. Okay, so the idea here is that there's a transport maximum when all the carriers are saturated, that you cannot move any more of that particular solute. You can't reabsorb it, and so it's going to end up in the urine. Okay, so this is just another image of items that are reabsorbed, and this time I just want to look at where they are reabsorbed. So the proximal tubule is the most, right? These substances are reabsorbed. Most substances reabsorbed in the proximal convolute tubule. And then the other two places are distal and collecting duct. We have another really large area. There's some reabsorption in the loop of some ions, but this is the most where you have a lot of more organic glucose, amino acids, vitamins, urea, and choline. All right. So then, what is it about the proximal convoluted tubule that allows so much reabsorption? And this is because they have very long microvilli. So they have a very distinct brush border to them. They have leaky tight junctions, so some substances can go right through the barrier between these cells. And then they are also stocked with mitochondria, which then can supply the ATP for active transport. Okay, so they are really prepared, and their job is to reabsorb. On the distal convoluted tubule and the collecting duct, it's not so much, right? We still have, most of our microvilli are gone. There are some cells that might have a little bit shorter. The tight junctions are actually tight, and there's not as much mitochondria. It turns out that the transport mechanism here in the distal convolute DCT or distal tubule and collecting duct are more regulated. So these respond to hormones. And they're going to be more of an on-demand regulated basis of what substances they're going to reabsorb. And then the proximal convoluted tubule, they're just built to reabsorb. So they're just always on reabsorbing. So this is what we call unregulated. So if you look at your Roman numeral 2 for regional specialization, non-regulated reabsorption in the PCT. So it's going to take up 70% of our sodium and 100% of our glucose right away. And the DCT in the collecting duct, letter B, it's only going to respond to hormones, so aldosterone and ADH. And again, we're going to look at this in the next chapter. The loop of Henle is a very big water conservation loop. So you can see that water is primarily going to be reabsorbed in the descending limb. All right, so let's take a look at our next topic. And this is going to be excretion rate and clearance. So excretion rate is basically how much of a substance is filtered and secreted. And then it's going to, you have to also take away what's reabsorbed. So excretion rate is how much of it is excreted from the body, right? How much leaves your body. And the amount that's excreted is going to be the amount that's filtered, what comes out of the bloodstream. Also, what comes out of the blood vessel, what's secreted. And then you have to take away whatever is reabsorbed, right? Because then that's not going to count as your excretion rate. So this is just a quick example of that. So if you have 0.08 millimoles per mil of a specific solute, you're filtering it, this is per mil, and you're filtered out 150 mils. If you do the math, that's 12 millimoles of that solute. And it's going to get excreted. Then here comes the secretion from your blood plasma, secreting another 3 millimoles. So that's going to make a total of 15. And then we're going to reabsorb some. We're going to reabsorb 6 millimoles. And so now we have 9. And so the excretion ultimately is going to be 9 millimoles of that solute. Notice also the water concentration went way, way down. You're going to filter the water. You're not going to secrete water. And you're going to reabsorb a lot of water, right? So you reabsorb a lot of water, and that's going to give you 5. And this is going to be dependent on your hydration level of how much water you're losing. All right, let's talk about clearance. So clearance is basically how much is cleared from the blood, right? And clearance is going to use for how well your kidneys are working, renal excretion ability. So basically what happens is every substance has a specific clearance. It depends on whether it's how easily it is filtered, the size of it, the molecular structure. So let's look at clearance for a second. So, let's look at inulin. So, when you are looking at someone's kidneys health, one thing that they can do, a clinical assay or test they can do, is to give you inulin. So I know this is a weird word. You want to say insulin, but it's not. It's inulin. Inulin is not something that we normally have in our bodies. It is a small little polysaccharide. It's harmless. But when you inject it into somebody because you're doing this test, it's going to get into their bloodstream, and then your kidneys will filter it out. And it is 100% filtered. It is not. So the filtration rate is going to be all of it, right? So filtration, 0.5 millimoles of inulin it's not secreted, and it's not reabsorbed. So for a molecule like this, what is in the filtrate, right, what's filtered is also the same as the filtration rate. So the glomerular filtration rate is the same as the clearance because they are the same, because it's not secreted or reabsorbed. So this clearance just shows you that when you excrete the same amount, so here we have the same amount, 0.5 millimoles of inulin come out in the filtrate. We are excreting 0.5 millimoles of inulin. This tells us that it's not secreted. We're not getting any more inulin in our excretion, and it's not reabsorbed because we're not getting less inulin than what's excreted. So if what's filtered and what is excreted are the same, that means that the glomerular filtration rate is the same as the clearance. Okay? If there's an imbalance of what's filtered and what is excreted, then we can start to make little calls. So let's just work with this for a second. Let's look at glucose first, and then, so glucose is another example of something that is completely filtered. So glucose is filtered, right, at 125 milligrams of glucose, and it's not secreted, so we're not adding to that, but it is reabsorbed, okay? So what's being reabsorbed is 125 milligrams of glucose, so 100% reabsorption. So what is the excretion? What is excreted is 0. So the clearance is 0, okay? The clearance here is 0. You did not clear glucose from the blood. So clearance is a way of just looking at your kidney function, because there's no way you can come in and there's no way you can sample from the Bowman's capsule. There's no way you can sample from the glomerulus and sample. What you can do is you can sample the blood and you can sample what's in the urine. So you look at the two amounts, what's in the blood versus what's in the urine, and you can calculate excretion rates, and you can also calculate clearance. So it just tells you how healthy your kidneys are working, because you can compare the clearance of substances to inulin. And then you can also make a judgment on how things move through the kidney. So let's take a look at this. If a substance is freely filtered and it's not secreted, it's not reabsorbed. So 100% of that substance comes filtered. You don't get any more from the blood, and you don't move any of it back. That means that the clearance is the same as your filtration rate. This GFR, right, what's being filtered is the same as what's clearing the body. Okay, so this example would be inulin, right? However, then you can say, okay, well, what about glucose? If the clearance of glucose was 0, right? So, and then let's just go back to filtration rate of glucose. 125 milligrams of glucose, right? It's filtration. So if the clearance is less than the GFR, then it is reabsorbed, right? And in this case is an extreme example because all of our glucose was reabsorbed, right? If the clearance is more than the GFR, so if you find that you have more substances in the urine than was filtered, that means that it's also secreted, right? It has to come from somewhere. You can see the filtration rate, but you don't know where else that extra substance came from. So it has to also have been secreted. So let's see if we can answer this question. A substance S that is freely filterable and is excreted at a rate that is lower than the filtered load. On the basis of this information alone, which of the following is the most precise conclusion that can justifiably be drawn regarding kidneys processing of S? Right? We know it's freely filterable, and what's excreted is lower than the filtered load. So which choice would be justifiably conclusive here? So if it's lower, we know that it has to be reabsorbed, right? So S is, we have reabsorbed here and we have reabsorbed here. May be secreted or and secreted. Do we know, according to what's said here, if it's definitely secreted? No, right? We know that it's definitely reabsorbed because we have less of it being cleared, but we don't know if it's secreted because we have no idea. But anyways, some of it could be secreted and then much more of it was reabsorbed. So the answer is B. All right, moving on to the last topic here. This is micturition, which is urination. And pretty simple. This is a lot of just review from anatomy. So urine is formed in our renal tubules and the fluid drains into the pelvis, into the ureter. And then from the ureters, they're going to enter the bladder for storage. Now, the bladder is smooth muscle, right? The detrusor muscle is smooth muscle. And there are baroreceptors with baroreceptors in the wall to detect the stretch of the wall of our bladder. Now, when you go to the bathroom, the micturition reflex is everything that has to happen when you go to the bathroom, right? You release the urine that's in your bladder. So let's take a look at that. So let's just review real quick that you have two urinary sphincters. You have an internal urinary sphincter that is actually just part of the detrusor muscle. So this is smooth muscle, and we cannot control this. This is involuntary. And then we have our external urethral sphincter. This is voluntary. Skeletal muscle, right? So you can control one sphincter, but you cannot control the other sphincter. So what happens when you void the bladder, or what's happening in the micturition reflex, is that you will feel the volume from that baroreceptors, right? We have an activation of these stretch receptors. Reflexes don't need the brain. Remember, reflexes are just spinal cord. So in the spinal cord, you have to down-regulate your sympathetic activity, and that's going to relax your internal urethral sphincter. This is what you cannot control, right? This is involuntary. And then your increase of the parasympathetic, your rest and digest, you will contract the detrusor muscle. So I don't know if you guys realize, but when you go to the bathroom, your bladder does squeeze the urine out. So you have this contraction of the detrusor muscle. Both of those will open up, right, your internal urethral sphincter, and then you'll have micturition. And then on the other hand, the voluntary, you have to decrease motor neuron activity. It's going to relax your external urethral sphincter, and it's going to open up your external urethral sphincter. So you have to open up both of your sphincters to get micturition, right? So when you go to the bathroom, you have to be in a state of relaxation, at least at this sort of reflex level, because you have to increase parasympathetic activity and decrease your sympathetic activity. And then you have to be sort of relaxed enough that your motor neurons are going to relax and relax your external urethral sphincter. So if something goes wrong in this reflex, you literally can't go to the bathroom, and this is called shy bladder syndrome or parauresis. And a lot of people have this issue mildly, right? So you go to the bathroom, it's a public restroom, you may not want to go to the bathroom because you feel shy. And you might have to go to the bathroom, but maybe you can't relax enough where you can actually let go. And that can be any part of this. But then it can become pathological. So shy bladder syndrome, I have a little blurb of it where you're tightening the internal sphincter. So the internal sphincter is going to be controlled by the autonomic nervous system, right? And then if you have some adrenaline, like you're feeling nervous, this is going to produce this involuntary activate basically your sympathetic nervous system, right? And because that's what adrenaline does, and it's going to then not open up that internal sphincter. So I'm not sure what the process is to treat shy bladder. I think of it's a relaxation technique. But anyways, I thought that was interesting because we can see that there's many parts of your nervous system that have to be coordinated just to go to the bathroom. All right, some review questions. Which of the following is not one of the functions of the urinary system? The answer is plasma protein. That's liver. Which of the following is not a secondary function of the kidneys? So A, B, and C are. Glucocorticoids is not. The rate at which a substance is excreted is known as what? And that's going to be clearance. Which of the following is not one of the basic renal exchange processes that can take place within the nephron? So exchange, filtration is an exchange, secretion is an exchange, absorption